Thank you, George, for your invitation. Don't believe this kind of guys, because if we trust them, we can stop right now and go back to the swimming pool and stop doing surgery. So I am not a fan of Napoleon anyway. I've got some conflict of interest, disclosure, nothing related to that presentation. So the title of my presentation is Models for Training in Microsurgery. So what is microsurgery? Microsurgery is only optical magnification and the use of fine instruments, and that's all. So if you look at what were doing the watchmakers in the past and actually currently, the microsurgeons, the difference between microsurgeons and watchmakers is that we do use 2 eyes and 2 hands, and they use only 1 eye and 1 hand. So this is what is nowadays microsurgery. So what will be microsurgery in the future? And if you mix those concepts, I mean the concept of microsurgery were in 1960s, 20 years later the concept of endoscopic surgery, and 20 years later the concept of telesurgery, means robotic surgery. If you mix these 3 concepts together, probably we will get robotic endoscopic microsurgery. Because what I want to say is that if we have to perform microsurgery still with large incisions, this is not the trend of all surgeries. So surgery is now going to minimally invasive surgery. And with conventional microscope, it's not possible. So with robots, we like in conventional microsurgery, we can get optical magnification and also 3D vision, but we probably will get in the future more skills. For example, we do not have haptic sensation today, but in the future with robots, probably we'll get a magnification of haptic sensation. For example, to do super microsurgery for very, very small with no names vessels, we probably will need some haptic sensation and all of the other features that you already know. So the talk is supposed to be about models for training. And in the course that we organized for many years in Strasbourg, we do use some models, mainly the Konnyaku model that Georges talked about. It is Japanese noodles. And also in the past we used to take earthworms before the Konnyaku, which is also a very difficult model. But the problem is that you can't introduce earthworms in a rat laboratory because there are different species, and Elena, probably you know that in the European law anyway, you can't introduce this kind of non-vertebrate animals inside a laboratory dedicated to rats and to other animals. So we can't use it anymore. And of course chicken thigh and rats and pigs and human cadavers. But what we think that is the best model for initiation in microsurgery is the Konnyaku. It's very easy to get from the supermarket. Just take it out of the fridge. It's cheap, it's sterile, so you can introduce it in the OR, and we got a certification from the hygiene department from our hospital, so this could be interesting for people who do not have a laboratory. Then you take the noodles and you cut the noodles with a blade. It's very easy. There is only one problem with the noodle. There is no lumen inside. So you have to create a lumen. And this is a part of the training. You have to find a very thin catheter, the one that we use for pediatric purpose. And then, so here we use a conventional forceps, but you can also use the robot to make the lumen, and this is very difficult to do. So this is a very nice model for getting basic skills in microsurgery. So when you make the lumen, you use two parts of the konyaku, and then you can perform the anastomosis. The speed is probably double. So as you can see here, it's very easy. You can here it's a 10-0 suture with the rubber. Then you can cut it. Then you can see very well the lumen of the konyaku. The wall of the konyaku is very weak. It's weaker than a rat artery. So that means if you are able to make a suture and anastomosis with a konyaku, it will be very easy on a rat or chicken thigh vessel to make your anastomosis. Because if you make any mistake, the wall of the konyaku will be damaged. And this is a model that we published. You can make also a patency test with it, and then you can eat it. So this is the basic, I would say, the basic model. So in my field, I mean in peripheral nerve and in hand surgery, you can get a little bit more difficult models like that one. So we set up in the IRCAD in Strasbourg this model of a forearm cadaver, and purely endoscopically, we are here in the forearm. We just reach the median nerve, which is here, and then you cut the median nerve. Of course, I don't recommend to do it on patients, but sometimes they have some, for example, a tumor, and you have to make a resection, a tumor resection, and then you have to do the suture again, a graft or a direct suture, depending on the size of the gap. Then you introduce a 10-0 suture through the trocar, and then you can perform the nerve anastomosis, as you can see here, like if we were in conventional microsurgery. This is a very good training, because with the konyaku, you master how to make an anastomosis in a very simple condition. Here it's about the same, but in an endoscopic area. That means you make it a little bit more difficult. And if you can do it with nerve, you also have to do it with vessels. So now the speed is 4 times than regular one. So you have to dismantle this vascular clamp because it's too big to go through the trocar. Then you find the artery. Here it's the radial artery, and you have to put the vascular clamp around the artery. Then introduce a 10-0, cut the artery, and then make the suture as usual. Of course, here it's a cadaver, so you can't check the quality of the anastomosis, but we can use PICS to do it with additional costs. So the first step is konyaku for basic anastomosis. Second step is to make the same thing, an anastomosis endoscopically. And then you can find more difficult operations. So in hand surgery, I would say that the most difficult operation is a replantation. So we did a long time ago, I mean maybe 6 years ago, this replantation on the forelimb of a pig, a live pig. So we did the amputation, and the only step that we couldn't master with the robot was the humerus osteosynthesis, because the robot is not able to do it. So we did it by hand, and all the other oh shit, what happened? All the other can you help, please? Because I would like to speak at the. All the other steps were made with the robot. I mean, all the other steps were made by not one robot. It was before. No, c'est okay. Thank you. So, but with 2 robots. At that time, it was a long time ago. So it's an old version of the Da Vinci robot. And this guy, a guy from Intuitive, Brice Hérin, And you can see that the pig is alive and anesthetized. And so we are setting the robot, the first robot. And then the other robot is going through the operating field. And what is very interesting in this installation is that usually when we are doing microsurgery, all the hands of the surgeons and the assistants are inside the operating field, and we do not have a lot of space to manage the anastomosis, so we can't perform two anastomosis at the same time. But with this, you can see that the two robots are in place, and the operating field is almost free. So we can like two surgeons operating together, because we've got here two robots. It's not a robot and an assistant. It's two robots. That means that we can perform two operations at the same time. And this is very important in emergency in microsurgery, because time is ischemia, and ischemia is potential failure. So it's important to save time. This operation was done in 5 hours, and it was a long time ago. We were almost beginners in robotics, so you can see that all the steps of the operation were done with the robots, muscles, nerves, artery, veins, and ligaments, even the skin. So I will move. Now you can see the two robots working together. One here is doing some kind of vein anastomosis on the posterior aspect of the limb, and the other robot is trying to make a dissection of the humeral artery, which is the main artery for the replantation. So we put some vascular clamp, double one here and a simple one in case of protection. And we were very beginners, so we were not so good at that time. And what you can see is something that is strictly forbidden in conventional microsurgery. Look at the position of the lumen of this proximal part of the artery, which is very close to the vascular clamp, about 1 or 2 millimeters. Usually in conventional microsurgery, it's quite impossible to go through the wall, because the size of the wrist of the surgeon is too big to master this correctly. But here with the small under wrist, it looks like it's very easy. So that means even if you are inside a very deep operating field, it's possible to make a suture. So this model, I mean, it's the most difficult model you can get. We call it the level 4. Is the model very interesting, because we can master all the steps of the replantation. And this robot is helping the other one to cut something, a thread, and then we finish the suture, the other part of the wall. And then when all the anastomosis has been done, we just have to remove the vascular clamp, and we have to remove that one, and then we will see the patency test. Of course, it's not good here because there is still a vascular clamp. So look, we will see that immediately the blood is going inside the artery with a small leak. And here the patency test, I mean, without sensitive feedback, very safe, it works very well. And now we just have to check, close the wound. We did all the steps, but the bone fixation, so up to the skin. And then we did a small scar in order to make sure that the operation was successful. And as you can see that it's bleeding, that means from a vascular point of view, the replantation was successful. So this is a very interesting model for young surgeons, because we do not have so much replantation as we had in the past in Europe, and so young surgeons don't have so much opportunities. And with a robot, we think because we don't have any evidence right now, when we will improve the quality of the magnification and also the magnification of the movements, we probably will be able to decrease the length of the operation, and every minute is important in replantation. So these are, I would say, the level of models that we can use, but I can't show you all the models that there are so many models in different kind of disciplines that, okay, it's impossible, but you have to think about initiation and then anastomosis and then operations. So we are doing a course in Strasbourg since 2009. There is a course twice a year, and only 6 participants can attend to the course, because at that time we had only 2 robots, and we wanted all participants to practice. Now in the IRCAD in Strasbourg we've got 5 robots. I think it's 5, Patrick. Okay, and we've got 53 participants in that course since 2009, and Siangir is here, is on the picture, and Gustavo Montovani. And 13 countries from all over the world since 2009. And we've got 2 or 3 experts on each course. That means that you have 1 expert for 2 participants, which is important because people can train. And you can see here the list of the experts who already participated to the course. And this is a 2-day course from now. A couple of years ago it was only one day. Now it's 2 days, because the cost is 1,200 euros for the timing, but probably it will increase. It starts with lectures from intuitive surgical staff. We explain how works the robot, and also from experts. Then we go to the lab, and intuitive surgical engineer gives some advice and presents the robots. And then there is a hands-on during half a day with a Konyaku model or chicken thigh or whatever. And then the day after we go to the OR to attend to a clinical case. I try to make a simple clinical case at the time, because usually for brachial plexus it takes a lot of time, so I don't want people to bother. And then to get a certification. And what is important to understand, that this certification allows you only to present yourself as a robotic microsurgeon, but it's not enough to be recognized by your hospital. You need a certification for basic robotic training. So it's not in 1 day and a half or 2 days that you will be certified, of course. So the next course is this November. Anyway, it's fully booked, so don't ask to come for next February probably. And what I would like to highlight now is that with 2 universities of France, which are not so far one from another. One is Nancy here, and one in Strasbourg, so it's about 150 kilometers distance. They would like, so University of Lorraine for Nancy, University of Strasbourg, they would like to set up an official robotic microsurgery training course. R3B in the School of Surgery of Nancy, and the other one in the IRCAD of Strasbourg. Here probably cadavers, and here probably on pigs. And if you agree with the auspice of RAMSES, and the company who is making the organization is the Stein Institute, with one represents at the back. So probably this course will take probably 5 days for basic training in robotics. It's not a problem for urologists because they are already certified. But for ophthalmologists, for plastic, for peripheral nerve surgeons, it's very important to take time to master the robot. So there will be a 5 days course focused only on basic training in robots, and after that 5 days you will get an official certification that you can show to your hospital. And then there will be another course after 2 days rest, visiting probably the wine tour around the area of Strasbourg. There will be a 4 days course, 2 days in Nancy to learn about plastics and also peripheral nerve surgery on cadavers, and then 2 days in Strasbourg for to learn how to harvest flaps and intercostal nerves in pigs. So probably we will be ready to do that in 2015. So Alex, I am right to say in 2015? Yes. We did not decide yet the date, but it will be
16 next year.
The next year, yes. 2016. 16. What did I say? 15? Oh. No, 16, sorry. So if you agree, guys, I would like to leave that to do this at the auspice of the RAMSES Society. Thank you for your attention.